It's great introduction, Kiran. Thanks a lot for that. And it is very nice to be in the my with all my friends, especially Rajiv. We did our MD together in Mangalore. He was my senior, and I learned quite a bit from him. And his passion, I think the passion what he has is something extraordinary. I think the same way he has worked in neonatology, and it's so nice to hear one of the dons of especially ARDS in the pediatric field, Peter, and the work which he has done. So I'll be just going through the pathophysiology because this is the, as Kiran said, it's the foundation of what really happens. But I'll keep my talk too simple because a large number of them is general pediatricians who are not a pediatric intensivist in this field. I think we have gone through the disclosures are none for this topic. And if you see, Dr. Peter has already told about the definition of this thing. It's a syndrome of acute diffuse inflammatory lung injury associated with a non-hemodynamic lung edema. See, basically, you get two types of edema. One is because of the left heart failure or sort of a obstruction to the pulmonary venous drainage. That's the reason why what happens is you get a non-protein rich fluid into the alveoli. Second one is direct because of the infections or direct injury to the alveoli, you have a protein rich fluid coming into the alveoli. Basically, the definition is whatever it is that consists of three things, which has been long time back has been described. That is the non-cardiogenic pulmonary edema. When you see the X-ray, there is bilateral pulmonary infiltrates, which also have hypoxia because heart is normal, but because of the lungs, because of the extraction of oxygen, you get hypoxia. And also in the absence of heart failure, that is very important. That is, you don't have a heart failure, it is non-cardiogenic error. And this, I think it's one of the causes that is, as you know, it's been described that direct or indirect injury, because direct is alveolar or epithelial injury. What happens is that common causes of direct lung injuries are basically pneumonia, aspiration of gastric contents, because here what happens is that whatever the cause is, like for example, pneumonia, infection, it causes injury to the alveolar epithelium, which results in the further cascade of problems, what happens in the alveoli. Second is indirect. It is not related directly to the alveoli, it's somewhere else, like something like sepsis, severe trauma, shock, and multiple transfusions. So majority of cases of AR, this is coming to the pictorial form, that is, as you see, like aspiration. One of the most common causes of pediatric is aspiration. More than that is pneumonia. Almost about 30% of ARDS, what we see in our PSUs because of the pneumonia. Then others like neo-drowning or direct injury, as I said, toxic inhalation injury, blunt injury. These are the ones which causes the direct alveolar damage resulting in ARDS. There is indirect injury, that is somewhere else, not from the basic lung alveoli, but it is occurring somewhere else. Most often is the sepsis, which forms again around 32 to 35% of the cases which presents with ARDS in pediatric age group. What happens is here, because of somewhere else, there is cytokine storm, which produces this inflammatory wall-like situation, which is overwhelming, which releases so many of these cytokines. So causing the indirect injury to the endothelium of the capillaries, which results in the alveolar damage and further problems. So coming to the epidemiology. So this is basically adult study which was produced about 32% sepsis and pneumonia. The sepsis, pneumonia, what I mean is not sepsis. What I mean is that it is not the pneumonia, the organism which is causing sepsis further causing this. This is sepsis somewhere else, resulting in ARDS. Aspirations form about 17%, trauma forms about 13%. So this is a PARDS study, which has been sort of told by Dr. Peter, that is about 145 intensive care units from about 27 countries took part in this. There were about 23,800 admission. Out of it, about 3% had pediatric ARDS, with about 17% of mortality, because though it was admissions were only 3.2% of ARDS was there, but it found about 17%. Earlier reports showed about almost about 30%, though the admission was anywhere between 1 to 3% of this. So coming to the basic thing about the pathophysiology or pathobiology. Basically, what happens is there is diffuse injury to the alveolar epithelium. And also, what happens is indirect injury. It is because of the capillary endothelial barrier. It's sort of a disrupted, resulting in a non-cardiogenic pulmonary edema. Let's come to that later. So what happens is that when there is an injury because of the cytokine storm, there is infiltration of the activated neutrophils into the alveolar space. So what happens is there is the barrier of the endothelium which gets disrupted. So you have a alveoli. Actually, see the wonder of the nature. You have a sort of a completely dry alveoli, which is sort of a hanging in the basket filled with blood vessels. You have completely a fluid-less alveoli, and you have a completely fluid-filled capillaries. So somehow it doesn't go between two, so it remains dry, and here it remains filled with blood. So what happens is because of this activated neutrophils, which sort of because of the disrupted endothelial barrier gets into the alveoli and causes this thing. This is a hallmark of ARDS. This is a slide which shows basically what in a child who has got a ARDS, which shows a dilated alveoli, which during this proliferative phase, what happens is there is initial dilated alveoli. There is, you can see this pink area, which are the hyaline membrane disease. And there are the areas, because what happens is in ARDS, there are areas of a normal lung, there is areas of a collapsed lung. There is also atelectasis, which is happening, or the involved lung. So in a given child with the ARDS, you have both a normal lung and a diseased lung. This is again, this pink areas, what you see is sort of a hyaline membranes which are formed in this. This is again, you can see in this pathology slide, that is, these are the alveoli, what you see here, which is filled with the proteinaceous material, the infiltrates like monocytes and neutrophils, and here it is just getting aggregated with this proliferative cells which is on the side. And this is again about 200 into 200 slide, that magnified 200 slide. Here you can see the deposition of this fibrin, which is producing the thickening of the alveoli in the later stages. Coming to the phases of disease that we all know, that all the pneumonias or this thing, they goes through these phases. So whatever the inciting injury which occurs, whether it's direct or indirect, the ARDS commonly progresses to the stages, because each one has got a different clinical manifestation. They have a different radiographic manifestation, and there is different histopathological features in this different stages. So what are the phases? Because here, if you see this picture, this sort of is a normal alveoli. You can see on the sides, this is the type 1 alveolar cells, and these are the type 2 cells, because you can see it is more flat, more squamous, and this is more of a cuboidal shaped cells. And it is completely free of, almost completely free of the fluid here. But what happens is that when there is capillary endothelial destruction, barrier destruction, or when there is a direct injury to the alveoli. So what happens is these are the macrophages, which sort of gets activated and calls the neutrophil inside, which can go because of the endothelial destruction, and the neutrophils migrates into the alveoli. So now what it does is it sort of produces interstitial flooding and coagulation. In the proliferative phase, what happens is there is increased and interstitial fibroblasts will come in, and finally in the fibrotic phase, what happens is there is interstitial and intraalveolar fibrosis which occurs, so that the alveoli loses its compliance, and usually it does not have the same architecture as the normal type. So if you see this picture, here you can see this is on the top part of the alveoli. These are the bronchial epithelium. So as the bronchioles come down, you can see this bronchial epithelium. Then these are the flat ones, are what are called as a type 1 cells. So type 1 cells are the ones which sort of line the alveoli, and the main function of it is to sort of in the gas exchange. It's an impermeable membrane. So here these are the type 2 cells. Type 2 cells have got a function of producing surfactant, and also for some this thing, it sort of allows fluid to pass from the alveoli into the interstitial space between the capillary endothelium and the alveoli. So whatever fluid which comes out, sort of in the interstitial space, gets absorbed through the lymphatics into the capillary and gets out. Now what happens is, if you see, this is a normal alveoli on your left-hand side, which has macrophages, alveolar macrophages, and this whole area is devoid of any fluid. But what happens here is, in the exudative phase, because of the disruption of the endothelial wall, and also whenever there is a organism, pneumonia occurs or sepsis occurs, these antigen, as it comes into the alveoli, it sort of the macrophages recognize it. They have what is called as a toll-like receptors on the top of it. It gets attached to that. Once it gets activated, it will release IL-1, TNF alpha, and all these substances, granular enzymes and all that. This, what it does is sort of a macrophages call the neutrophil inside, because there is also disruption of the endothelium of the capillaries. So what happens is there is disruption. So all this thing, neutrophils goes up. When the neutrophil goes into the alveoli, it sort of produces severe cytokine storm-like situations, so many enzymes and all that are relieved, and there is severe inflammation which occurs. So to sort of kill the organism or neutralize the antigen, but there is a lot of other things which is happening. And see here, this is the type 2 cells. It loses its sort of ability to push out the fluid, and that's the reason why there is a lot of fluid which occurs. When there is this reaction which is happening, there is a lot of hyperpermeability occurs, and the dry alveoli start getting right, and the protein rich, like a gel-like consistency fluid sort of is formed in the alveoli, which is not drained. Whereas in left heart failure or a cardiogenic edema, what happens is this protein poor fluid, but here you get protein rich fluid in the thing. This is again a diaphragm, which what really happens between the alveoli and the endothelium layer during the exudative phase. Here you can see that there is increased alveolar capillary permeability. You can see the disrupted what we call as a VA cardin. These are the bonds which sort of between the endothelial two endothelial layer. It is there and prevents anything going from the thing. So because this is disrupted, there is a fluid leak which goes into the alveoli and causes the problem. So coming to the exudative phase, it is characterized by acute development of a decreased pulmonary compliance and arterial hypoxia. What happens is, as the fluid comes in, protein-rich fluid comes into the alveoli, it's sort of a surfactant production is lost because of the destruction of the type 2 cells. And also, it is neutralized also. So, yeah, as you know, the surfactant gives you a sort of a increase the surface tension, produces surface tension. So when it's decreased, the alveoli loses its complaint and loses its shape. When it happens, so there is arterial hypoxemia. So what are the clinical features in the exudative phase? They have tachypnea, they have a hypocarbia because of increased breathing rate, diffuse alveolar infiltrate on the X-ray due to pulmonary edema. So what happens at the alveoli? As I said, in a direct injury, that is that directly like pneumonia, drowning, aspiration, etc. Early pathological disruption of diffused alveolar damage. The initial effect is in the alveoli, which is suggested by in predominance of alveolar epithelial injury in this direct injury to the lungs. These causes uncontrolled release of what we call as a damage associated molecular pattern, because toll-like the receptors, pro-inflammatory cytokines, they're immediately released because of the attraction of the neutrophil inside the alveoli. So indirect lung injury, like for example, sepsis, acute pancreatitis, etc. What happens? There is cellular injury, whereas somewhere else, maybe you take it as the sepsis or abscess somewhere else. So it's a distant pathology which is there, which in turn, through the endothelium, it can damage the pulmonary endothelium and which sort of disrupt the alveolar barrier, resulting in dysfunction. And what happens is, whenever there is so much of inflammatory cascade which is going on, there is also coagulation disturbances. And also what happens because of the microthrombus, the pulmonary vascular resistance increases, pulmonary hypertension increases. There is VQ mismatch, ventilation perfusion mismatch, poor oxygen, and also because multiple thrombus and inflammatory reaction, they can go in for multi-organ dysfunction. So coming to the capillary endothelium. So this capillary surface, to understand this capillary surface of the endothelial surface has got what is called as a glycocalyx layer, which sort of prevents any sort of a free passage of any substance. So injury to the glycocalyx is an important mechanism of increased alveolar permeability. What happens is it gets disrupted in the indirect injury. So restoration, because if you see, as the resolution and the recovery of ARDS takes place, there is a restoration of glycocalyx, which results in the recovery. So this is a picture of what is a normal endothelium. You can see here there is a monocyte. This is inside the blood vessel capillaries. So platelets are there. You can see this beige colored sort of a thing from the endothelial cell till the up what is called as a glycocalyx. Now what happens is, once the activated granulocyte comes here, it disrupts this glycocalyx. Once it disrupts, this injured endothelial cells becomes permeable. There'll be thrombosis, there'll be increased residue of core protein which occurs in this thing. Now coming to the next stage after the exudative phase, what we call as a fibroproliferative phase. This is basically when the repair starts happening. Because what happens is, after about 7 to 10 days, the chronic inflammation and scarring of the alveolar capillary unit with increased alveolar dead space fraction happens. What happens is that because of the inflammation and scarring, the alveolar unit, because if you see earlier, it was like a balloon which is sort of a fully full of air. Now there is decreased dead space, which is some of them are atelectic and all that. So because of the thrombosis and mismatch, the refractory pulmonary hypertension can occur because the right to left shunt is occurring at that stage. So if you see this is from the proliferative phase, as it happens, because there'll be phagocytosis. Then what happens is these are the bronchial epithelium which is there. This is where there was the type 1 cells were there. This is the fluid, protein-rich fluid is there. This is basically what we call as a hyaline membrane. So here what happens is the type 2 cells, what happens is they can differentiate. They are mitotic, whereas type 1 cells are amitotic. They can't differentiate. They die. So these are the ones starts differentiating. So what happens is there, and as the inflammation starts subsiding, there'll be wound repair. The type 2 differentiates into type 1 alveolar cells. Cell proliferation and difference occurs. And more important is if it's more injury, there is proliferation of fibrosis. That is, fibrosis formation occurs. These are the fibroblasts from the endothelium starts getting here fibroblastic cells and start sort of a depositing here wherever there is injured area and forms a sort of a honeycomb formation. So when there is severe injury, there is severe fibrosis which occurs, and with the deposit of fibronectin, whatever is cells, neutrophils will be there, they'll be taken up by the macrophages, cleared off. Same thing happens with the different proteins and other cells which will be cleared. Apoptosis occurs. All those things will occur. So stages, as I said, it's already been sort of dealt with the Dr. Peter, that is edema, which occurs in the first 2.5 to 3 days. Then the hyaline membranous formation from about a day to 14 days. Alveolar pneumocyte hyperplasia, which occurs, which goes on, and interstitial fibrosis feeds from the thing. This is an X-ray, which is the child will come initially. This is on the first day. Second is on the second day. You can see the infiltrates which are coming here. And third, this was on the 5th day, which occurs. It's almost getting like a whiteout lung. You can see in the different phases. Last one is where that's in the exudative proliferative phase, almost like a whiteout lung. So in the recovery phase, there is restoration of the alveolar and epithelial barrier. Whatever that barrier which is lost, where there's fluid coming in, neutrophils coming in, that starts getting sort of restored with the fibrin deposition and the repair. And clinically, the child will be gradual improvement in the pulmonary compliance, resolution of arterial hypoxemia, then finally return to the normal function. But some of them may not, because as I said, there are areas of normal lungs. There is also areas of dysfunctional alveoli. So these are the different phases, as I said, exudative phase, which is lasting for about 7 days, and proliferative phase anywhere between 7 to 21 days, and fibrotic phase occurs from 10 days onwards, about 10 for 24 days. The resolution also starts. It can go on for months together. This is typically what we learned in pathology. So stage of congestion, stage of red hepatization, stage of gray hepatization, red hepatization, and the stage of resolution. So molecular mechanism, it's because of the dysregulated inflammation, which is pathophysiological hallmark of ARDS. And pattern recognition, as I already said, it is important that pattern recognition receptors, such as toll-like receptors, which are highly expressed in the lung epithelium and alveoli. What happens is the lungs are basically never exposed to the what is in the blood, because that endothelial barrier is there. Because once the disruption occurs, all these pathogens, cell-injured derivative molecule, all sort of come into the alveoli and cause this problem. So alveolar dysfunction and edema formation, integrity of gas-blood barrier is maintained by tight junctional complexes in the alveolar epithelium and a capillary endothelium. These cells are connected by a protein complex called adherent junction. Injury to this complex are the major cause of exposition. Let's see this. You can see these are all we have what learned as a tight junction. You can see here between the cells, you have what is tight junction. This is the endothelium. Endothelium also has got this gap junction and tight junction, which is there. So here, because of this neutrophil action, and what happens is there is paracellular permeability. So what happens is the interstitial fluid sort of increases, the distance between these two increases. What happens is, because if you know, oxygen and carbon dioxide, they don't travel far. So as the gap between the alveolar epithelium and capillary endothelium increases, there is fluid there. So the exchange of oxygen and carbon dioxide also does not take place in a proper way. That's the reason why they can get hypo. Finally, coming to the mechanism of alveolar fluid clearance, the capacity of the membrane protein to effectively regulate alveolar fluid balance is reduced because of the epithelial damage which occurs. Exposure of the alveolar epithelium to hypoxia also inhibits the transepithelial sodium transport and decreases the overall alveolar fluid clearance. What happens is, as you know, the cells of the type 2 cells, the tubercle cells, they also have a mechanism of lung fluid clearance to the sodium pump. So this gets damaged. So whatever capacity they have to sort of clear this fluid goes up, so the fluid accumulates in them. So these are the newer insights. There's a lot of newer insights are coming into the what happens in the pulmonary edema. So these the this how this tight junctions are disrupted. What are the mechanism which is occurring and which is exciting. So what happens because of the surfactant? All of us know in newborn what happens. So what happens? This is, see, on the first picture, you see a alveoli which is collapsed. Here the surfactant is diminished. Say the surfactant is diminished. As per the Laplace law, the surface tension sort of depends upon the amount of fluid or air which is there and into the radius. So what happens is, if the surfactant is not there, then the compliance of the alveoli goes and sort of it loses its shape. When it loses its shape, because it is easier for alveoli to expand from an expanded shape, rather than, that's the main basic of giving the P, keeping a higher P. So what happens is, once it's already sort of lost its shape and atelectasis, to sort of expand, it really takes a large amount of pressure. So this is one of the major problems what happens with the decreased surfactant. There is alteration in the lung capacity. What happens is here that edema reduces the compliance and end expiratory lung volume. The functional residual capacity, that is the amount of air which is there in the lungs after a normal exhalation, and you have what is called as the residual volume, which is after the forced expiration. There is also what is called as a closing volume. This closing volume should be always below the total lung capacity. But the alveoli, which has lost its compliance and shape and atelectasis, what happens is that functional residual capacity becomes lower than the closing volume. When that happens, it really needs a higher pressure to open this alveoli. This is what the physiology of it. So what happens in the gas exchange in acute lung injury or ARDS? In ARDS, what happens is there is fluid-filled alveoli. When there is fluid-filled alveoli with a low ventilation, perfusion units are there, because whatever it is, there is no gas exchange which is taking place. So alveolar over distension in other area creates a dead space. So there are areas of normal alveoli, areas of fluid-filled alveoli. There is over distended alveoli which is there because the ventilation perfusion mismatch is going to happen. Now, when if you give here 100% oxygen and you have the capillaries here, so wherever there is normal alveoli, the oxygen takes place. But half the oxygen goes to the other side, which is filled with fluid. So here there is no transport of oxygen into the capillaries. So this is so only about 50% you get. There may be a big over distended dead space. This thing. There also it does not take place well. So this causes the intrapulmonary shunting, which is the dominant cause of arterial hypertension. This is basically the pathophysiology, but it is sort of a diverse, because ARDS is caused by so many different type of pathology, like direct injury, indirect injury, maybe sepsis, all those things. With the with this, I would like to summarize that ARDS is an inflammatory lung injury associated with the non-hemodynamic lung. It is not a cardiac edema. It is non-cardiac edema. Various pathophysiological mechanisms at play, as we know. It follows that different phases into the recovery stage. the activation of monocytes, which triggers the inflammatory response, leading to alveolar epithelial and capillary endothelium damage, is the hallmark, and it is the main cause what happens for the damage. And atelectasis gives rise to ventilatory perfusion mismatch, and there is all new insights into molecular biology can reveal a better understanding. Thank you so much.